questions. Our next talk is by Indranee Rajapreyar, who's at Thomas Jefferson University, Director of Mechanical Circulatory Support and Program Director of the Advanced Heart Failure and Transplant Cardiology Fellowship, and she's going to talk about cardiogenic shock pharmacotherapies, pearls.
Thank you so much for the introduction. Thank you, Dr. Karan, Jim, Marwan, for the invitation. Again, it's an honor for me to be here to talk about pharmacotherapy and cardiogenic shock. So I have no disclosures. I would like to start with the definition of shock, which again is simplified state of ineffective cardiac output caused by primary cardiac disorders causing clinical and biochemical manifestations of inadequate tissue perfusion. The clinical manifestations including sustained hypotension and decreased urine output due to end organ hypoperfusion, and then certain biochemical parameters like elevated lactate, acidosis, and parameters of end organ hypoperfusion like serum creatinine and transaminases. So this is a nice illustration showing the downstream deleterious effects of low cardiac output and congestion, how it leads to hypoxia, endothelial dysfunction, inflammation, and when vasoplegia sets in, I think it's pretty much, I call the end stage of cardiogenic shock, where you have altered response to vasoactive drugs, you have metabolic acidosis, and then develop multi-organ failure, where you're probably not able to resuscitate patients from. So this is how I approach a patient, and shock, rapid assessment, and triage is really vital to basically ensure success. There are some patients you may not be able to basically escalate support because they're not candidates. We talked about, Dr. Berkoff talked about phenotyping shock, assessing the severity of shock. Etiology is key to proceed to the next step after initial stabilization. Hemodynamic phenotypes and comorbidities is key to ensure success. So one of the things I practice is that not one size fits all. You develop a personalized approach to manage these patients. Start treatment targets, initially set treatment targets, hemodynamic and tissue perfusion, microcirculation, which I think there'll be talks about that, and treatment of specific etiology, and frequent reassessment for escalation and consideration of MCS, and consideration for combination MCS and vasoactive therapy in hemometabolic shock. And shock team engagement, one designated team along with nursing staff will monitor the progress. Next steps, crucial, I think treatment of etiology is going to be key to decrease mortality in these patients and palliative care engagement. So we all know the SKY staging of shock that talks basically was proposed to define severity of illness. We all know cardiogenic shock presentation is a spectrum. You can have patients who have isolated myocardial dysfunction. You can resuscitate with pressors and inotropes, and there are patients who are in stage D, stage E shock, near hemodynamic collapse, where you need to escalate to mechanical support and use adjunct inotrope therapy. So these are just biochemical markers and hemodynamics that define each SKY staging. And initial assessment, we talk about this echocardiogram, EKG, lab data, and hemodynamic assessment. Again, we all know that Swan or right heart caths are not available everywhere, at least a central venous line to assess RA pressures, and basically central venous SAT to calculate cardiac output may help. So etiology, again, it's important to assess or find out etiology because that will dictate treatment. And we talked about the hemodynamic phenotypes based on the volume status and circulation. Again, we talked about BIV shock or isolated LV, RV shock, and tailored therapy according to that. So goals of resuscitation, again, the focus should be to restore pressure, flow, and also, again, etiology is important for success. So blood pressure targets, a primary vasoconstrictor strategy may impair tissue perfusion, so I think it's important to restore pressure and flow by decreasing preload, afterload, and also increase contractility. So there's no data on optimal pressure targets in cardiogenic shock. Most of the data is extrapolated from sepsis trials. There's one study that looked at cardiogenic shock patients where the patients who had a MAP less than 65 in a 24-hour period had increased mortality, likely cause association or reflection of severity of illness. So I say BP targets should be individualized and not used as a sole parameter to treat cardiogenic shock. Mean arterial pressure is not tissue perfusion in my mind. So lactate clearance, we know that lactic acidosis is a marker of microcirculatory dysfunction, and several studies have shown that presentation lactate more than 5, acidosis, and lactate at 8 hours, and decreased lactate clearance, and also rising lactate are predictors of increased mortality. So there's one team that proposed that presentation lactate more than 6 or rising lactate at 90 minutes should be a trigger to escalate or initiate MCS support right from the get-go. So I talked a little bit about metabolic acidosis. I think it's important to restore perfusion and initiate renal replacement therapy early on because you're going to have reduced vasopressor responsiveness and impaired cardiac contractility and altered SVR. So this summarizing, this is a table summarizing the perfusion. There's no real perfusion targets, as you can see, this guidelines by several societies. So going to pharmacotherapy, the two vasopressors and inotropes are the first-line treatment for management of cardiogenic shock. The two most common inotropes that are used are dobutamine and milrinone. We all know that dobutamine acts by the beta-adrenergic pathway to increase contractility, but also vasodilates in the peripheral vasculature, and milrinone inhibits the PDE5, is a PDE3 inhibitor and increases CAMP and increases contractility. Several facts, quick facts: dobutamine has a quick onset of action and it's rapidly reversible. There's no role for going up beyond more than 10 mics per minute, kilogram per minute, because you're going to have arrhythmias. And in patients who have ischemic cardiomyopathy, it may increase worsen ischemia. Eosinophilia, it can cause eosinophilic myocarditis. I usually prefer dobutamine because it has a quick onset of action. Milrinone typically has a half-life that's prolonged in patients who have renal failure, and patients who have a low SVR state. You may precipitate refractory shock. Alpha agonist vasopressors act in the periphery by increasing calcium and vasoconstriction and increase SVR. These are this is just a table summarizing all the pressors with their usual infusion doses and receptor binding, receptor affinities, and the hemodynamic effects. It's one important caveat is that you want to use pressors for the shortest duration of time and lowest effective dose. And when you're when you have persistent tissue hypoperfusion with 2 vasoactive medications, or if you're using more than 0.5 mics per kick per minute of norepinephrine equivalents, then you need to escalate to mechanical circulatory support. So this is just a slide summarizing different how you calculate the norepinephrine equivalents. And then there's really lack of high-quality evidence to support strategy, initial MCS versus vasoactive strategy. There are 3 trials that looked at vasopressors and inotropes and cardiogenic shock. One is the SOAP2 trial that compared dopamine versus norepinephrine. There was increased mortality at 28 days. And then you have the OPTIMAC trial that compared norepinephrine and epinephrine in a very small cohort of cardiogenic shock patients. There's no difference in mortality, but there was definitely more refractory shock and lactic acidosis, and increased at 7 days in the epinephrine group. So, and then the last trial, the DORAMI trial that compared milrinone and dobutamine in cardiogenic shock, that did not show any difference in mortality. So basically, there's no convincing data to support any specific inotrope or vasodilating therapy in cardiogenic shock to reduce mortality. There's still an unmet need. And however, the guidelines recommend norepinephrine to be the primary, the first-line agent to treat cardiogenic shock. Basically, I use a combination of norepinephrine or dobutamine unless there are certain conditions where you would use primary alpha agents like aortic stenosis or mitral stenosis, or patients with dynamic outflow tract obstruction. So for RV shock, basically preload optimization, maintaining perfusion by increasing contractility, and afterload reduction with vasodilators. The choice, vasopressor choice and inotrope choice would be dobutamine and vasopressin/phenylephrine. Metabolic optimization, sedation protocol, correction of hypoxia, and early initiation of mechanical ventilation. Vasoplegia is one of the things that is challenging in end-stage cardiogenic shock, inability to maintain blood pressure with low SVR due to inflammatory cytokines, adrenergic receptor desensitization. So it's just a chart showing treatments, methylene blue or vitamin B12 or angiotensin II. And in summary, just restoration of micro and macro circulation with the lowest effective doses. MCS should be considered in hemometabolic shock and treatment of specific etiology. There's still gaps in knowledge. Vasoplegia syndrome may be challenging and needs to be recognized and treated early. And basically personalized approach to management in an individual patient with cardiogenic shock. That's it.
Great talk. Gary?
Thank you. Enjoyed your talk very much. And I do agree, restoring tissue hypoperfusion, improving end organ, those are goals of therapy. And how I'm digesting one of the goals of this symposium is where are the opportunities to improve outcome?
Yeah.
And I love your thoughts on the concept of not only escalating in a timely manner to achieve these goals, but de-escalating therapy in the context of going big up front to treat biventricular failure. So if you can share your thoughts on de-escalation opportunities.
Yeah, so I think that's where the frequent assessment in the ICU is key with invasive hemodynamic monitoring, where you would use certain goals to de-escalate if patients are improving, if there's lactate clearance, then basically de-escalating or weaning off pressors and inotropes. Or in patients you've escalated to MCS, coming off vasoactive medications because they are, again, toxic to the tissues. That's my approach. I think frequent assessment, and it has to be, going and seeing the patients. I mean, setting the goals with the nursing staff, actually. The nursing staff are very key in, help with de-escalating vasoactive medications. I don't know if that answered your question.
Dr. Savansky?
So thank you. That was a wonderful summary. I wonder, as a critical care doctor and a trialist, one of the things that I struggle with is that most of the surrogate endpoints that we look at, mean arterial pressure, PaO2, cardiac output, have not consistently went in the same direction as things that patients care about, like mortality and getting out of the hospital. And many of the trials that people have started to look at, and you mentioned a few of them, and there's been the more recent 65 trial that suggests that minimizing exposure to things like vasoactive medicines that might have harm might be reasonable in older patients. So can you tell me, how do you weigh those two things, trying to avoid under-resuscitating or under-treating your patient, but also trying at the same point not to give somebody a therapy that might lead them to bad things?
Yeah, so I think rapid early stabilization, and I think this should not be any compromise in blood pressure or flow restoration, be it with vasoactive agents or escalating to temporary MCS. And I think that's where we have to really decide if there's rising pressure requirement, you escalate to temporary MCS. And I would not withhold therapy initially seeing a patient in cardiogenic shock. I think rapid assessment, start vasoactive therapy, escalation to temporary MCS. And I think the most important thing is treating the underlying etiology. Someone has severe AS, are we going to do balloon valvuloplasty or get them to the next step? I think that's key, and that's why these trials are not really reflective of what's happening, because each patient has a different etiology for their shock, and if you're not able to treat the underlying problem, I think we've failed. I think vasoactive agents are just a temporary measure to get them to the next step.
Thank you, Indranee. I think Sri is standing there and asking a question.
The talk is about pharmacological therapy for cardiogenic shock. So I still see the guideline says norepinephrine. It's toxic. It's vasopressin. It's basically increasing the SVR. It's going to cause a downward spiral. From your talk, it appears to be intuitive, if you're going to use hemodynamic profile, to use a combination of an ionodilator and a vasoconstrictor if need be. So in other words, milrinone and vasopressin seems to be a better choice where there's not going to be elevation in PVR, because the first talk, which Dr. Burkhoff said, high CVP is bad. So RV is failing, that means everything goes down. So our goal should be more in trying to see what we can do to offload the RV to the LV. So can you comment on using
Yeah,
that?
so the dobutamine, milrinone, I think I prefer dobutamine only because, one, these patients that we see in shock, they have renal dysfunction, and the onset of action for milrinone, it takes at least 30 minutes. It's dose dependent. With dobutamine, the onset of action is within minutes. And I think there is a role where you can transition them from dobutamine to milrinone later. And the PVR decrease, I think you're right that milrinone does decrease PVR, but in a way that the SVR goes down and your PVR goes down. You're lowering the left-sided filling pressure. So I'm not opposed to using milrinone. It's just that in patients in shock, you can end up in a vasoplegic state if they have renal hypoperfusion and delayed clearance effects. So dobutamine is on and off. So using dobutamine with, yes, norepi has some beta effects. It's going to be overlapping, but still, I think for me, I could turn off dobutamine quickly if there's vasodilatory effects of dobutamine. Whereas I'm struggling with milrinone if they have worsening renal dysfunction. So
I'm just still curious why the first-line agent is norepinephrine in the guidelines, where you can use vaso plus milrinone combination for cardiogenic shock.
no, I agree with you, and I that's basically, there's no data, there's very limited data, I think, based on the Optimac trial, and also the fact that there's no data really. I mean, there's no data really to support what we're doing, but norepinephrine seems to be the less toxic compared to epinephrine and, vasopressin. So I think that's the reason for the norepi, I think.
Thank you. Ali, a quick comment. We are running a little late,
Just
so
quick
go ahead.
question and about what you think about levosimendan. Levosimendan is a drug used in Europe, calcium sensitizer, and with success for short term. And we don't have that here in the United States, unfortunately. I have good experience with that from my back work in Germany. What do you think about that?
I have no personal experience with levosimendan, but it seems to be a good drug. The thing is that it also has a vasodilatory potential and it's renally cleared. So you could still have lingering effects, but certainly that's something could be used like milrinone. But it's a calcium sensitizer, and it does, I wish we had that here for some of our patients, for a select cohort of patients. But I have no experience with it.
Thank you. We'll continue the discussion. Just to let you know, Dr. Van Diepen, who wrote the guidelines on the pressor use in shock, will be here tomorrow, so we can continue this discussion. Thank you, Indranee, for a great talk.